So, winter's night, and it's very good of you to turn out, and we've got a little bit of stuff to talk about first before we get on with the proceedings of the evening, which is a major contribution by the medical students of the medical school here, which we're going to be very grateful for. First thing, just to remind everyone, is the Burns night, which is due on the 3rd of February. There's still plenty of tickets available. Could I urge people to come along if they're at all interested? And you don't have to be Scottish. We will accept English and even Welsh. The other thing that's terribly important is that I've been browbeaten into this moustache challenge. And this is the finished product. I don't know that I'll get there by the 3rd of Feb, which is when it's going to be ritually shaved off in public at the Burns night. And there is a website which you can use, the Just Giving one, which you can find, I think, fairly easily. For goodness sake, please do some sponsor. I'll tell you I'm going through this. Sorry, I'll just go back to the beginning of the show. The other thing, just to say, is that at our last meeting, we had a collection for the Royal Medical Benevolent Fund, which is a fund that looks after doctors that are in distress, and although we think doctors get very well paid, there's no doubt there are doctors who fall on hard times for various reasons. And John Bruce has very kindly been the regional representative for this, and the collection has managed to get us £400, which actually I think is very significant. So anyone who gave money to that, I'm very grateful to them. The next talk on the 2nd of February, again at the Queen's, is another meeting joined with the Bart Medical School Fund, and this is going to be on the birth of plastic surgery. Jonathan Goddard actually used to be one of our trainees in urology in Nottingham. He's an extremely good speaker. He's very, very keen on medical history, and in fact has opened for the British Association of Urological Surgeons a history of urology website with all sorts of interesting things. So that should be a very good talk. He's an excellent speaker. That's all I've got to say about what's coming. So we talk now about tonight, and we're very pleased, I think, for Nottingham to have had a medical school for all the many years now. It's been an enormous benefit to the delivery of medical care in Nottingham, and actually students are enormous fun to have around. We're lucky that they still do just a little bit of urology, and I'm very grateful for Tom Bracewell here, who was on the firm doing urology a couple of years ago, and distinguished himself by his long blonde hair and his Ray-Ban glasses, and occasionally giving the correct answer to a question. But he showed star quality. Tom's already distinguished himself because he's been the Nottingham University Entrepreneur of the Year by actually selling lots and lots of T-shirts. Is that correct, Tom? A few T-shirts, he said. He's already a multi-millionaire. Is there a website that they can...
Somewhere, yes.
There is. Does that have Bracewell in it, or...?
Rise Worldwide.
Rise Worldwide. There we are. So that's there we are. So I can see Caroline Anderson over there, last year's president, in a wet T-shirt, which looked wonderful. I also need to say big thanks to the medical school, and Ian Hall, the dean, who's very kindly come tonight, so be on your very best behaviour, you students. In fact, the Bart Fund does sponsor the Medico Chirurgical Society to the tune of £4,000 a year, and actually that has given us financial comfort, whereas it's actually been up till then quite a tricky thing trying to balance the books, so we're very grateful. So I think if I could hand over to you, Tom, and you tell us what you've got in store for us this evening.
Yep.
We're all very much looking forward to it.
Well, I've got a microphone in my hand, but I think I could probably just manage the microphone on. So, first, welcome and thank you for coming to the medical student MedChi Careers Balloon Debate. we hadn't got any balloons due to a technical fault last year for those that were here, and the balloons caused more problem than they were worth. I've got a delightful photo of me from first year there, which was taken on day 3 of medical school, looking very awake and attractive. I say so myself. In terms of tonight, the way it's going to work, we've got 8 people representing 8 different specialities, and they've been allowed a strict 3 minutes and 3 slides per presentation. There are some who've already broken the rules, so you can berate them as you wish through their presentation. There will then be a vote, and we'll get to test out the technology and see if that works. And the winning 3, the top 3, will then get a further 1 minute and an extra 1 slide if they would like to present their case for why their speciality should win. And then there'll be a winner and some sort of exciting ceremonial presentation, I think. So here, to accompany my lovely first year photo, here are all 8 of the first year photos from the 8 speakers tonight, looking very young, Bobby. Wonderful. And yeah, without further ado, I think we'll move on to. Oh, this is the other thing, sorry. There's currently a revision session for fluids going on next door for final year students. It's now all but Steve are 5th year students with finals 4 or 5 weeks away, and there's a couple of 5th years in the audience, which I'm very grateful to see. And so here's your fluids revision, just a sort of recap on what's going on next door, so you don't feel like you missed out too much. Question? Yeah, well, I've probably got handouts somewhere. If you want to come see me after, I'm sure I can sort that out. And that is an actual paper as well. I have to go back and look at how to do references to get that in the right order. So starting first up is Ben Baker. I put walking mood on there because he recently broke his ankle, so it's nice to see he's all healed and getting better, and he's going to be talking about academic medicine. Ben Baker.
Hi. So thanks, Tom, for the pleasure of opening this. Nothing to do, of course, with the fact that my name was first alphabetically, but the fact that you wanted to hear what academic medicine has to offer. So instead of showing you a series of gory images and war-stricken zones, I've chosen to show a screen full of dots. It starts off quite philosophical and goes quite rapidly. So these dots can represent a number of things. I think the red one is the academic medic, and the black ones can represent one of 3. Firstly, all the patients you may affect with one foul swoop of genius, not just the ones around you, not just the ones in your hospital, but maybe even patients worldwide. They may also represent clinicians which you need, and with clinicians relying more heavily these days on evidence-based medicine, of course that will be an important part of your role. And thirdly, they might represent all the facets of modern medicine which are yet to be inextricably linked. So how are we going to link these facets? How are we going to lead clinicians? And how are we going to treat and manage patients without research? Anyway, eponyms. There's always a chance, isn't there? So I tried to get a few late related ones up there. I managed Ambison, but unfortunately started the wrong spelling. The best I could manage for Lemberger was Bamberger. Sorry, John. The work you've done there. And there's also this guy, he's my personal favourite, Ernst Grafenberg, and he managed to discover the Grafenberg spot, otherwise known as the G spot, so it's not without divulging too much about his experiments, apparently he was quite a pleasure to be around. And just taking this back to a bit more of a serious note, I've got this quote from Steve Jobs. A man whose mate said to me, I don't know why he shared a quote from Steve Jobs, because he wasn't an academic, he was actually a creative person. And I thought, well, you've got to actually be quite creative in the first place in order to think up an idea and go on to prove that may be the case. And I won't patronise you by reading the quote out, but I think it just shows that you never know, one day the dots might suddenly come together, and if you are in academic medicine at that stage, then I don't think there is a more rewarding career to be. Thanks.
So next up we have Rob Griaux representing urology. Now we don't actually have any representatives from the GEM school here tonight, but we do have the next best thing, which is Rob. I mean, he is aged wonderfully over the last couple of years. He's rumoured to have David Cameron on speed dial. Ladies and gentlemen, Rob Griaux.
Thank you very much. It's been a hard 5-6 years, as you can see. It's been a transformation, to say the least. I've got the lucky job of speaking to you, or the slightly hard job of speaking to you about urology. Too easy. And why it's the number one specialty for tomorrow's doctors to think about. It's a relatively small specialty. You know, there's only about 800 consultants nationwide. Apparently only 3% of them are women, so women, you should be starting to think about going into urology. And it is quite a hugely varied specialty. I've got a few jokes, we're going to throw them in. So a patient goes to the urologist for a follow-up. He gets into the clinic room. Why are you laughing already? How many of the joke? He gets into the clinic room and waits. Finally the doctor comes in and he asks, what's the problem? What's my prognosis? The doctor calmly looks at the patient and says, you're in trouble, mate. You're in trouble? No? Okay, you're in trouble. Urology especially is often overlooked by certainly undergraduates. I've only had a week of it during medical school, but it is really hugely interesting. It combines medicine and surgery, it combines babies right up to the elderly patients, so it's quite varied, and that's what certainly attracts it to me. It's relatively simple, you know, it's a tubular system from one end to the other, something needs to flow through it. Urology is more complex, you know, it's obviously a lot more complex than that, but essentially it's quite a simple amount of knowledge with a lot of hard procedures and surgeries alongside it. Surgical techniques are varied. I like the idea of there's robotics now in some sorts of urological surgery, which is very interesting. There's also minor operations. The thing that I also like is the fact that it's not all surgery based. There's lots of outpatient involvement. You can actually see your patients through, unlike A&E. They might cure a few, they might save a few lives, but they never really see a patient through on their journey. So I like the fact that urology offers that. Another joke, because there's loads. It's quite an easy one if you type it in on Google for urology jokes, but to try and play the audience correctly. So why are urologists smarter than neurosurgeons?
I don't know.
It's because they deal with the really hard stuff in life. Personally, I actually want to do paediatric surgery, so paediatric urology. That's where my specialty lies, and that just is one of the many subspecialties within urology. It's very competitive to get into, so I probably won't get into it, but I'll give it a go. It's all about teamwork, and there is also the possibility of private work, which is always nice to think of in the future. There's a lot of other careers in medicine, just a few of them are here today. Academic medicine is obviously hugely important, and academic urology, I suppose, is also a hugely important area. Orthopaedics, you're going to get from Pampy in a minute, who's the classical, stereotypical T&O person, plays rugby. Just think whether you trust your mum's hip replacement on him when he does it. The other ones, army medicine, obviously I'd actually really like to do army medicine, and anaesthetics. There is a joke about anaesthetics, but I don't know what I should say. But what is the difference between an anaesthetist and a urologist?
I don't know.
The urologist plays with someone else's willy all day long, and that's what you've done.
Enlightening, Rob, thank you. Next up is Emma Hartnett. Now, you may be wondering why BGT is up there. Emma asked me not to tell you this, but I thought I still would anyway. Emma is a keen musician and trombonist, which you can think about while she's speaking. Emma's band Satsuma recently made the cut, the first cut through to Britain's Got Talent, where there's now only 600 people left in. 70,000 acts down to 600, and she's also in a band with Pampy as well. So that's my fact about Emma. Emma's also dyspraxic, so she asked for 25% extra time on the 3 minutes, which she was refused. Sorry.
Okay, so I'm here to remind you all why cardiology is the specialty that you should go into, or should have gone into. So first of all, I like to compare it to the 4 Ps. So first of all, our world is changing. People are becoming more and more obese, and with cardiovascular disease being a disease of the obese, you'll always be needed, you'll never be out of a job, so it's a very important job to go into. Secondly, there is the option for private work, very topical at the moment, of course. So for those of you who are a little bit more money-driven, then that's always an option. And thirdly, we all went into medicine to save lives, and as a cardiologist, you have the option to be saving lives all the time, doing CPR, so you actually have a lot of power. And fourthly, we've all been medical students or are currently medical students, and we all know that medical students are always in the way, and as a doctor you always want to be able to get rid of them. So as a cardiologist, this is a very simple thing to do. All you have to do is show them a ECG. So to finally persuade you, I've just got a few statistics to show you why you should do cardiology. So firstly, actually almost half of all deaths in Europe are caused by cardiovascular disease, so it's very important. And even more shockingly and even more sad, it's actually every 17 minutes someone's heart is beating. And the last two, I can assure you of their validity, but I don't actually have time to explain where they all came from. But I'd like to leave you with one final thought, which is, if you've broken lives and broken hearts in your life, isn't it about time you started thinking?
So next up is Tom Pampiglione. He is, as already been stated, your typical rugger bugger. He is the current chairman of the rugby club, and which is quite surprising, really, seeing as he's representing TNO tonight. And he's, as I said, he's also in the band with Emma Satsuma. So Tom Pampiglione.
I was going to try and break the stereotype, but I think I'm in a bit too deep, so just roll with it. Alright, so I'm here to talk to you about trauma and orthopaedics. I think if we go back to sort of the beginning of medicine, hundreds of years ago, what happened was you caught an infectious disease and you either lived or died. But trauma and orthopaedics was really the first sort of medical career that could really even begin to make a difference. Starting off in medieval battles, you might have a primitive cast made of a bandage soaked in horse blood that was left to dry. And then many advances have been made through war and the battlefield to try and get your soldiers in the best back to full fighting fitness. So things like intermedullary nailing, external fixation were all invented on the battlefield. And these things can therefore be taken into the general population. Sir John Charnley invented the hip arthroplasty in the 60s, pioneered. Got a commemorative stamp after him in 2010, which is always something to aspire to. And these things can then be taken on to today, where the future lies in things like robotics. This is a hospital in Texas where they're using 3D modelling and robotics to remodel articular surfaces. So really, you've taken all these things to the battlefield, which is where most technology, in fact, is invented, and then into general population. And what does that mean today? Well, we've got an ever-aging population, and that also increases the burden not only on all specialties, but also orthopaedics, with this arbitrary sort of figure, more at the top. And the further up you go, the older you get, there's going to be a greater calling on joint replacement, and it's an expensive procedure. So, future technology, there's going to be money going into it to make it better, to make it more streamlined, and it's an exciting place to be. We're right at the head. There's 300 years of medicine behind us, and it hasn't changed that much because it works. It's not archaic. Not other medical specialties can say they've got that history behind them and that proof of work. The best thing about orthopaedics is somebody comes into you, no matter whether they come from the acute setting or chronic patient you've been seeing for years and years, but what you can safely say to them is, I can do something about it. And the best thing is patients can get better. You've got the nice variety between acute care and also chronic disease, and you can really, really do something about it. I can't really think of another specialty where people can, in the long term, can look to be on less medication than when they came into hospital, apart from perhaps pathology, but... So why do I want to be a trauma and orthopaedic surgeon, alright? As a teenager, there were 3 things that really took up a lot of my time. The first one, gadgets. Everybody loves a new gadget, and trauma and orthopaedics have got loads of them. And the best thing about that is they're continually being developed, because the future lies in it. They get tools that are better and better at doing the same thing. But that advancement means that your career never stagnates. It's always exciting, it's always fresh. You never get stuck in the same thing. The second thing that took a lot of my time, playing sport. And I don't mean that in a competitive sense, although it would be naive of me to think that I wasn't about to embark upon a competitive career. What I mean is... That wasn't a joke. We can joke about my career future, if you like, my career prospects, ST4. No, it's the fact that you've got the dedication to put something at the end of it. You've got something to show about it. So that could be a musical instrument, any hobby that you're willing to put the time and effort into to show something at the end. And finally, something that I used to spend quite a lot of time thinking about as a teenager, girls. Now, I did have a slightly different picture up, but I thought they were the sort of girls you wouldn't want to bring home to your mum. So I've gone with the safe bet, Keira Knightley. Surgery is a lot like chatting up girls. At first, you're completely rubbish, completely hopeless, can't do anything on your own, fumbling around, useless. And then you get a big brother to put his arm around you and show you the ropes. And yes, sometimes he will shout at you if you mess it up for him as well. But eventually you get better and better, keep going on, and then you get to a stage where you might be able to do some of the easier ones yourself. Come on, hey, mine's up the gutter yet. And then eventually you carry on, you get that one direction, that one route that you want to go towards, that sort of Walt Disney princess that you're willing to spend your life doing. But you have to be prepared. Sorry. You have to be prepared and willing to spend your time doing it, because the further you get along the career, or the metaphor, the harder it becomes to change your mind. Thanks very much.
You didn't mention the high risk of infection.
I'll sit down now. Thanks very much, Jason.
Thank you very much. Next up is Sam. Now, I've said a quick thank you to Sam specifically for jumping in relatively last minute. Please don't feed Sam sweets or caffeine because he's hyper enough as it is. Sam,
Thank you. Hello. So I feel like I'm being converted here because, hey, chill down. Because talking to a bunch of hospital consultants about GP is weird. So, before I do that, I thought I'd be a bit like a Republican politician at the moment and slander my colleagues. Okay, so why not check? Why not check out our future cardiologist? She will really be milking it tonight. And our pretty pink academic. And here's our stereotype orthopedic surgeon. Oh, there we go. And I don't think I really need to say much more about it. A little bit of a dance there. And here's our army boy. Also, interestingly, a paper published recently showed that statistically you're more likely to get shot working as a GP in Nottingham than in the army. And of course, she's a wannabe A&E girl, but she also likes to dress up as a girl from the Only Ways Essex. So just use this? Is that better?
Yeah, both works.
Okay. Both work. Use both of them. And of course, I don't really need to say much more about this. So, seriously though, what than being a general practitioner. Well, don't snort. Last remaining generalists, probably. Internal medicine, paediatrics, gynecology, psychiatry, and of course, getting to work with kids. That's just because I think, children are fun, and you get to mix it up. Also, that's my grandma. You get to go on home visits and see old people, so you get a big spectrum. Continuity of care, dealing with people from when they're born to when, well, they're older, probably not when they die, because you'll probably be dead by then. But somewhere along the spectrum, and getting to deal with the families as well. The specialist GP, I'm sure everyone here loves them. Family planning. Then we've got the GP with a special interest in sexual health and contraception. Working with the homeless. Minor surgery. And how many surgeons here can say they've had a massage while doing a minor operation? I don't know. Also working with drug addicts. So independence, own boss. So if I wanted to paint my room purple, I could. If I wanted to go for a run in the morning and postpone my clinic, probably could. Work-life balance. Here's me in the gym. Here's me playing golf. Here's Emma, who's a cardiologist working really hard, putting on a few pounds. Here's stressed out Tom. He's worried. Ageism. A few other fatties. Oh, sorry, Matt. Give me a little bit of time there. Challenging. So query more so than hospital medicine. I don't want to be what it is, but it's complex, multifocal, pragmatic. I know that doesn't say pragmatic. I'm dyslexic. But dealing with complex challenges with people in the community, not often dealing with just one problem, but multiple problems in one go. And also efficacy of work. A few years ago, WHO published a document saying the benefits of primary care, focusing primary care versus secondary care, tertiary care, showing that countries that focus more on primary care had decreased mortality, morbidity, decreased major cardiovascular and respiratory disease, as well as decreasing the social economic gap and increased patient satisfaction. Not to say that there's not a place for hospital medicine, but by focusing on the primary care, it can be a serious benefit to patients. That's the study if anyone's interested. And again, so thank you very much. Yeah.
Next up is Laura Sophie James. She's talking on accident and emergency. Everyone speaking tonight was in alphabetical order until I worked out that I got where the hyphen was in Laura's name incorrect. So it's not Laura, it is Laura hyphen Sophie James, whereas I thought it was Laura Sophie hyphen James. So that confusion is the reason why Laura is out of position and the reason I get 25% extra time during exams. She was known as Ice Cream during the first 3 years of med school for her attractive and scary stare, with evidence in the first year photo, and she's been announced an emergency.
Okay, so I'm talking about accident emergency. So why do I want to do emergency medicine? Well, with this in mind, I decided to interview some of my siblings who aren't medics about what hypothetically they would like to do if they did medicine. My older brother Tom said that he'd like to do gynecology, because there's always a lot of openings there. And my sister Emma said she preferred to do one when you don't touch people. She doesn't really want to do that, so she thought maybe she'd look at x-rays. I did think maybe she could do some psychiatry, but she hadn't realised those people were doctors. Okay, so and my mother confirmed she hasn't really grasped the last 5 years, and she said, "Oh, so you decided to be a doctor then? Cheers, Mum." So I found this algorithm on the BMJ website, and as you can see, you don't need much to do emergency medicine. You need to be crazy, admittedly, check. check, and you have a shorter attention span, which is something I'd definitely be willing to work on. I find it strange the Ireland is quite so trusting of the medical school process. At no point does it say to you, you're not suitable for medicine, please leave. Maybe that's what I like about emergency medicine though. It's not complicated. The medicine can be, but at the end of the day, you turn up, shift work, which is a bonus. You see whatever comes through the door, prioritise as appropriate, and at the end of the day, you go home, never see the patients again, fingers crossed. So how can I defend wanting to work there day in, day out? I'm not sure a childhood of avid casualty and ER watching does it, nor does liking your 1 week on critical illness placed there. Saying that though, myself and my cardiologist friend Emma did win an award for our week on A&E. It was really exciting until the award was given to us, and it was for the most failed cannulas in a week. I like the idea I could potentially use all the medicine that I've learned. I don't want to spend 5 years learning the entirety of Kumar and Clark just to spend a morning doing 50 cataract surgery. I like an A&E to a famous Forrest Gump quote. It's like a box of chocolates. I think that with emergency medicine you get to see the weird, the wonderful, and the downright strange. And to that end, Tom Bracewell has kindly lent us a film that's taken with him on a recent visit to A&E. Here's hoping he's bought me a pair of glasses. On a more serious note, I did do medicine because I wanted to have the skills to help people. It wasn't just a line that I pulled out for the interview process. Part of my reason to do medicine was loss of friends and my father's work colleagues in 9/11. I look at worse asses and I think, if and when this was on my doorstep, I want to be able to do something that can help. And what speciality would better prepare me than emergency medicine? Finally, something my dad used to say, choose a job you love and you'll never have to work a day in your life. This is true for my brother Tom, who's chosen to be an academic at Cambridge. This will never be true for any of us. However, I'm happy to work hard, do something I love, and hopefully one day I'll live out this penguin.
Next up is Matt Taverner. He's possibly the cleverest person I think I've ever met. It's rumoured that he's not actually taking finals and he's just scraping off an honorary NRCP. We'll see what happens. Matt Taverner.
Well, thank you very much for that rather undeserved introduction. I definitely don't sound clever, from the north and all that. But I'm here to talk this morning, or this evening even, about anaesthetics and why it's such an awesome speciality. And I've been entitled to talk An Expert's Guide to Sudoku, because let's face it, most people think they need to just do Sudoku half the day. But being a gas man is quite difficult, and you know, there are some very common misconceptions that a lot of doctors have about this speciality. To start with, people often think they don't like talking and don't like knowing how to talk to patients. Instead, they fill them with this white stuff made from eggs, and then they instead interact with their patient via a machine. They spend all their days on their iPads, and we've often seen anaesthetists with an iPad, or, more commonly, an iPhone. And the iPhone is becoming very common in theatre, whether you're an anaesthetist or a surgeon. I think you can do your portfolio as an anaesthetist on the iPhone now, you don't have to write anything down. And a very common misconception is they have weak grip strength. They're stupid and not funny, according to a recent study in the BMJ, which compared the orthopaedic surgeons like Tom with the anaesthetists like me, and I'm sure if me and Tom had arm wrestle, I know we'd be in that contest. And then they spend all their days being servants, and I'm sure we've seen this very famous servant on TV recently, Carson. He's very popular, he's very nice, and anaesthetists often aren't seen like that at all. But I want to spend a few minutes just looking at the reality of the situation. The reality is that anaesthesia is the biggest speciality in hospitals, and it has lots of subspecialities. It's not just about putting people to sleep. You can do kids work, you can do obstetrics work, you can do cardiothoracic, vascular, compatibility, you can do anything you like in anaesthetics. You can be a pain specialist and work in clinics. You can be an intensive care doctor and help treat the sickest people. You can in effect be the hospital for the hospital. And you can also work in pre-hospital care, so you can do what Laura's doing, you can do whatever you want with anaesthetics within reason. You avoid a lot of hassle. I'm sure we've all had and all seen before those heart-sick patients, those patients who come back in, I've got back pain, I've got back pain, I've got back pain. Well, in anaesthetics you avoid that, you avoid the clinic most of the time, and if you are in a clinic you're doing something very good about it, like sticking a needle in somebody's back and giving them an epidural. It's very practical as well. I mean, I've got a picture here from ITU and all those lines and all those things, and the dicky bone, all indicative of an anaesthetist. Very hard-working, very diligent, and a bit eccentric. And if you like teams, you'll like anaesthetics, because there's loads of teamwork in the anaesthesia. I've never seen a team work so well as that team that's in the theatre working with the anaesthetist. And once you leave work, you actually leave. You can completely forget about what happened in the day. You hand over to your consultant colleague, and you forget about it. And most importantly, you save, change, and improve lives. You save lives as a pre-hospital medic. You change lives as an obstetric anaesthetist or as a pain specialist, and you improve lives by helping all the surgical specialities to do what they do best. Remember that, guys. Without anaesthetics, no surgeon will be able to do their job. So, if you vote for me, there'll be one more quote from a very famous person to sell the argument for why anaesthetics is the best speciality in medicine. Thank you very much.
I'm taking through to the final speaker tonight, which is Steve. He's the another special thanks to Steve. He's the only fourth year member speaking tonight, the baby of the group, and he's going to speak on army medicine.
Thank you very much, Tom. So I'm Steve, and just in case you did miss that introduction and you missed the title on the next slide, hopefully the background will remind you that I'm going to be speaking on army medicine. It looks like it's into that a little bit, but we'll crack on anyway. Very quickly, the career path of an army medic can start as early as when you're doing your AS levels, and if you're lucky enough to choose this speciality then you get an incredible amount of help from the army to further your career with a cadetship, and that's worth sort of £15,000 to £18,000 a year while you're training, and I'm sure that's something that students amongst us can think about and regret not doing as we kind of go back to our freezing cold houses in Lenton and almost do with a bit more cash. I mean, we've missed that boat, but that's a very good thing. The other thing, if you don't do a cadetship and you don't go into the foundation programme, then obviously you can enter as a specialist and you can work in the territorial army. So you just do 19 days training a year with them, you get paid to do that training, and then you can go and also get specific army medicine training with the army and also be deployed on tour, so you can work as a specialist. There's also the opportunity to work in this country or abroad in barracks with soldiers and their families. As Sam was talking about the life of a GP, you can also do that within the army. Over here we've got the extracurricular opportunities. So if you're a very active person, very sporty person, like to stay in shape, there's all sorts of opportunities in the army to stay fit, stay healthy, and there's always somebody around to try something new with. So if you want to go skydiving, thank you very much. If you want to go skydiving, if you want to go scuba diving, if you want to climb a mountain, then there's all sorts of opportunities to do that kind of adventurous stuff in the army, and that's one of the things that really appeals to me. Moving on. Right, so skills building. Aside from being quite a one-sided sort of person focused on the military, you learn all sorts of transferable skills. So one of those things is how to take responsibility. If you're lucky enough to join the Army Foundation programme, then you're given your own GP list from your first week, which I don't think is something that happens when you first qualify. I'm not sure, but I don't think it is. You get to sort of learn those skills very early on. You get to practice from a very kind of early point in your career, and you can kind of get better and better at that. The other thing is leadership. Obviously, the army has a very hierarchical structure, so you've always got someone to look after. You've always got somebody who wants your advice, who wants your counsel, and you can have a real impact on young people's lives who've just come into the army. You can give them advice about their life, and the sort of the leadership that's taught in the army is some of the best in the world. So that's a really good opportunity that you don't really get anywhere else. Very strange. The Rangi of the Naval Coordination is obviously something to think about when you go into the army. So mostly you'll be treating sort of young, mainly healthy, mainly fit and well men and women. So really the frustrating thing that you often get with GP or you often get in cardiology is trying to get people to make the right lifestyle decisions, like eat healthily and exercise, that kind of thing. Luckily in the army, for the most part, that's taken care of. So really you can kind of get down to the nuts and bolts of actually practicing medicine sort of try and convince people to change their lifestyle. And the other thing is the satisfaction that the treatment that you're going to be giving them is going to get them back to a longer and really good high standard of living, and so the quality of life you're able to give your patients is a real plus. The last thing is a little bit of a cheap shot. Oh no, we've got a couple more things. So travel. So the last couple more things is travel. You can work abroad in barracks. So the British Army has got places in Gibraltar, in Malta, in Cyprus, where you can go and take your family and work if you're lucky enough to. And the other thing is, as Pampy outlined earlier, that in the army, you're really at the cutting edge of practice. Things that happens out on the battlefield is brought back to the NHS and implemented to help people at home. So it really does sort of cover all bases. And as I said, my last slide is a bit of a dig at everybody else. So that was the list, not including me. That was the list that I got from Tom, telling me what everybody else was talking about, and really army medicine sort of covers it all. Broadly speaking, academic medicine, the army does actually have its own, the Royal Army Medical Corps does actually have its own journal, so that's all right. As for the others, I'm not sure, but that's sort of the enduring memory I want you to have of army medicine, is that really you can do any speciality you want and still work for the army. Thank you very much.
Now the moment you've all been waiting for, I'm sure. Here's the list of everybody. The people who would like to vote Ben Baker, who was talking about academic medicine, who's up first, if they would like to raise their hands, we'll have a go at...
How many times are you allowed to vote?
You're only allowed to vote once. Once. Only once. Okay. 7. Yes. Okay. And Rob, who was talking on neurology. Oh, come on. 3, sorry, I simply don't believe it. Emma, talking on cardiology. 1, 2, you do get to vote. 1, 2, 3. Debbie and Rob. Laura, Sophie, Ben James, A&E. Tom Pampaglione, trauma and orthopedics. 1, 2, 3, 4, 5, 6. 6. Sam Pandey, GP. Oh wow. 1, 2, 3, 4, 5, 6, 7, 8. Matt Taverner, anaesthetics. 8. Surely not. And then Steve White, Army. 5. 5. Let's go to the top 3.
So the top 3.
Number 1, Ben Baker, academic medicine.
Ben Baker. Number 6, who was
Sam Pandey, GP, and Matt Taverner, anaesthetics.
brilliant. So that's fantastic. So well done, first round winners, and commiserations to all those of you who've got no career options in medicine. The cases are very nicely argued. It is difficult to choice. So are we ready to go on then?
I think we are,
Yes.
That's what everyone else is. I don't think Ben should go first, unless he really wants to go first.
I agree.
Yeah. Sam, you can go first. No. Have you got any more slides, or are you just chatting?
Let's load it up. The original thing. So I didn't back myself. Right. No, what can we not? Is it not?
Is it on the desktop?
Who wants to look at the pictures again? Anyone? No, so I've got a joke.
You want the flowers up? Is that what you wanted?
Yeah, please. Just something in the background to make us feel good. I honestly didn't prepare anything for this thinking. However, a joke, so a general practice joke. So a patient goes to the doctor and sits down in the chair, and the doctor looks at them and says, "I'm really sorry, I've got some bad news for you and some very bad news for you." And the patient looks distraught and really upset and says, "Oh, fine, well, I'll have the bad news first." And the doctor says, "I'm sorry, you've got 24 hours to live." And he goes, "That's horrific. What on earth could the very bad news be?" "Well, I've been trying to contact you since yesterday." That's basically it. But I'm very pleased that people enjoyed a talk about general practice. And so thank you very much. I think that's a minute.
So I wasn't expecting either to win, but I backed myself this time. You know, I thought, you know, I'd prepare just in case. What anaesthetists do best, prepare just in case. And you know, we've heard an argument this evening about why anaesthetics is good, but I've told you the argument. I want you to hear it from a famous Briton who was voted Britain's most famous historical figure a few years ago. And Winston Churchill. We wouldn't be here speaking English unless Winston Churchill was the Prime Minister in 1945, and he has this to say about anaesthetics. He said it in 1947. I'm not going to insult your intelligence by reading it to you, but I think it's quite clear that if a winner can back anaesthetics, then certainly anaesthetics deserve to win. Thank you very much.
Tom's going to need a lot more time to read that.
Why not perhaps? You did a little bit of a...
Yeah.
Is everyone read that?
Yes.
So, I did back myself. And I would have got a copy of that. So I may check that out. Okay. So that is an undergraduate fungus, or an undergraduate depiction of a fungus. And as you can tell, I haven't learned this slide very well. And that is actually called Aspergillus terris for the purpose of this talk. And to be more precise, produces MK733. It isn't actually a drug. But it was prescribed 83 million times in the USA last year. And that is now the second most commonly prescribed drug in the UK. And of course, all of us that are about to sit finals know that that molecule down the bottom right corner there is in fact simvastatin. We can stand here now an hour arguing about simvastatin, but apparently it was discovered all on very flexible and sociable working hours in active medicine. That's the end of my last
slide. So now technology failed, we'll go for another vote of hands. Who was first? Sam. So for those who think that Sam should win with his well-prepared discussion about GPs, if they could raise their hands, or if no one's voting for him, that's fine. 7, which I think we can definitely say that means you've lost, looking at the but wait and see. And second, Matt, who was talking about anaesthetics there. If everyone wants to raise their hands and vote for Matt. And then finally, Ben for academic medicine. 11, which puts the winner as Mr. Taverner.
think that's fantastic effort. Lots and lots of preparation. I'm sorry the keypad stuff let us down again, because it actually was working brilliantly earlier on, wasn't it? So it was, because I was here with you. I'm thrilled with all your presentations, and really nice of you to have sorted it all out. And I hope that you do devote some thoughts to choosing your careers, because it comes very quickly these days. Matt, thank you very much. Very pleased that you've extolled the virtues of anesthesia, but very, very disappointed, actually, that for the second year running, anesthesia has been the winner. I don't know what it is about it, actually, because I thought still the most popular career choice of Nottingham undergraduates was general practice. Maybe anesthesia is now going to sweep the market. I'm deeply disappointed that urology was approximately last. Note the fact, I think it was very, very badly presented. So, luckily, we have here with us tonight last year's supreme winner, Dr. David Bogod, who's going to be able to present, Matt, to you the prize. So, David, if you would like to come this way.
Thank you very much, John.
I have here a bag of prizes. I wonder what you think that is. Let me discreetly hide it round here. Okay.
And this goes to Matt. It's really nice to see a sensible judgment for a second year running.
Not sure about that. They all get a bottle each for completing.
Thank you.
Not Tom, though.
No, you don't get to.
Very sorry.
We haven't forgotten you, Tom.
No Tom.
That's for me, and that's for Tom.
That's for Tom.
Thank you very much, Tom. And I think it falls to me to propose a vote of thanks. It was a very interesting set of presentations. Tom Pampiglione, particularly, who, in keeping with the specialty he supports, orthopaedic surgery, ran twice as long as he was supposed to. I actually have a horrible feeling I was at medical school with your father, Tom. Is he Julian Pampiglione? Yes. I have so many stories. If you think Tom was a rugged bugger, my God, you should have seen his father. Congratulations to everybody here today. It's delightful. You've all put clearly a large amount of effort and work into this, and it's nice to know that in the future, patients in Nottingham may never get any better, but at least they'll die laughing. Congratulations to you all.
That's the end of this evening's serious academic presentation.